My name is Gary Bain. I've been involved in wound management practice for nearly 30 years. For 25 years it was my privilege to be the director of a wound management service at the Sydney Adventist Hospital. I'm now in private practice, caring for patients and also educating my colleagues in both nursing, medical and allied health professions. Something I'd like to talk to you a bit about is the idea of wound cleansing. We know that wound cleansing is an important part of caring for a patient and in preparing a wound to get it into a healing phase or to a phase where it's at least manageable and a patient's symptoms are controlled. We know that cleansing is important to reduce a bacterial presence on a wound, to reduce debris from a wound and to prepare a wound for procedures like wound swabs and for wound biopsies. Tea tree is known to have antimicrobial, antiviral, antifungal and anti-inflammatory properties. We know that it has been reformulated in recent times, and I would like to tell you a bit about my experience with a product called Perifoam. I've used Perifoam in clinical practice myself for well over a decade, and I know that it has been used in many other settings as well. It has a surfactant which does help you lift and break down slough to clean a wound. It does have an anti-inflammatory component, and it certainly has its antimicrobial effect. And we can see this with how quickly a wound tends to reduce its volume of exudate, how the pain level is decreased, and importantly, how smell in a wound can be minimized. And this, of course, has great benefit to a patient where smell can be socially isolating, making them feel unwell and even more ill in themselves. Here we have a male patient in his early 60s. He has had a venous leg ulcer. He's had a recurrence recently, and in the last 10 weeks his wound has been treated with dressings and appropriate compression, but the wound cleansing has been done with Perifoam. Here you can see Perifoam being applied to the wound. Perifoam can be left on and will itself break down and degrade on a wound surface. However, for the point of time management and perhaps patient or clinician preference, it can also be easily washed away, and often just potable water is all that is required for that purpose. And here you can see the Perifoam, having been applied, has started to gradually break down on the wound surface. And here you can see Perifoam now being gently removed with a dampened gauze cloth to reveal the wound surface. And you can see that as the Perifoam does come away onto the cloth, that there may be small pieces of tissue there taken away with the actual agent and the cloth itself. This may be the elimination of some slough from the wound surface.
As a primary care nurse in a busy general practice, I look after a wide variety of wounds, from the very simple to the most complex. And in recent times, one of the most complex wounds I've ever had to care for was a really large malignant wound with a metastatic squamous cell carcinoma, which involved virtually the entire left hemisphere of the patient's face and scalp. It was the sort of wound which was at great risk of catastrophic hemorrhage, so the wound was not suitable for debriding. Our main goal in caring for that patient was to maximise the quality of life where he is now, and to maintain that quality of life where the malodour associated with a malignant, highly exudating wound was going to be incredibly socially isolating for him. Looking after this gentleman's wound, requiring dressing 3 times a week, usually second daily, trying to offer the best cleansing option for him, it became apparent to me very early on that there were very limited options, certainly limited effective options in being able to cleanse the surrounding skin as well as a large fungating wound. Perifoam revolutionised my view of how I was going to care for this wound. I was able to cleanse all of the surrounding skin thoroughly, gently and effectively without causing any pain. I was also able to apply Perifoam over the wound itself and not have to worry about removing it or flushing it. I was able to leave it in situ. The malodor, which I first encountered with this patient, which I knew was a major problem for him, malodor was completely managed while we were cleansing with Perifoam. Our greatest success in the use of Perifoam for this patient, I believe, was in controlling the malodor. For a wound which was both highly visible and extremely malodorous, it had the potential to socially isolate him completely. But with Perifoam, we were able to completely control the malodor in a very gentle and effective way. He was able to carry on living his life in what is the palliative stage of his disease. When I would question him sometimes on a Monday morning, having dressed him on a Friday, "How was your weekend?" I was concerned about how his pain may have been controlled. I was concerned that perhaps he hadn't left the house over the weekend. He would report to me that he'd been out celebrating, had been to a blues festival, or had been out to celebrate a family birthday in a highly social situation, completely at ease. And I felt as though using Perifoam in that circumstance actually gave him back his dignity. I felt I had very limited options in cleansing that wound effectively. Perifoam delivered the perfect solution.